Welcome. Thanks for joining our Research Info series, A Blind Date with Knowledge. I'm your host, Laura Brady. Today, I'm with Dr Ben Prudon, who is going to give an insight into the COVID treatment trial, Recovery. Ben, thank you for agreeing to have a conversation with me. Just for a bit of background, how you found research in general, what was your first experience with research in the professional environment?
Yeah, okay, so I'm a respiratory consultant, so through my medical student training I had a period of research when I was doing my undergraduate training, and then I've been involved in research during my respiratory training, and so since being a respiratory consultant I've been involved in a number of different projects, primarily as a principal investigator, investigating an area, a wide range of respiratory diseases, including pleural disease, asthma, and so I've got that background of both being involved at a trainee level but also as a consultant delivering it at a PI level. Yeah,
you've been through all the stages of the process. So with you having a lot of experience of a PI role, how was Recovery, the trial? How did that compare to other projects that you've been
So in some ways the Recovery trial has been very easy to be a PI for. So if we go back in March 2020, it was at a very sort of uncertain phase. So we had effectively a new disease of which there was no evidence of how to treat it, and all of us were trying to prepare for an incoming wave. So back in March 2020, we knew London was about to get quite hot with COVID cases, but up in the northeast we had a little bit of preparation time.
Yeah.
So we were waiting to participate in all the studies that came along, of which the Recovery trial was going to be the big platform-based study to get involved with. And the team at Oxford who run the Recovery trial very much wanted it to be a pragmatic study for a pandemic. So the challenge with getting involved in research typically is there is quite a lot of assessments, and the patients you are trying to investigate for a particular disease becomes very selective. So often you have to go through screening many different patients before you can identify the one patient that fits the criteria.
Exactly. Eligibility criteria is often very, very specific, so it doesn't leave you with a big pool of people to
Exactly. But and there can be very specific timed investigations needed to be done in a very particular way, and that can be quite challenging because it means that the number of staff members who can do those investigations, look at all the different assessments, can be quite narrowed. So the way that Oxford set things up was it was very much everybody is suitable for the trial. It was very, very minimalistic on additional requirements. So effectively it was a randomised controlled trial, but it did not include in the early phases additional blood tests or additional assessments. So it was standard clinical care, which meant it was actually quite easy to get patients involved with from a PI perspective.
Yeah, definitely when the need is there to kind of get it through quickly and make sure that it's still of the standard that we require it to be. So how did those two things come across? How did you set up this trial? Or how did the Oxford people, I guess, set it up in quite a new way, but how did they maintain the integrity of the data that's obtained throughout the trial?
So the Recovery Central team had online educational resources that each person involved in the trial needed to complete. So but these were actually relatively simplistic videos, because effectively we were starting medications which were generally already used in the clinical workplace.
Yeah, a lot of those compounds have been used to treat other things already, right?
Yeah, exactly. So most of the medicines are repurposed medicines. They're not medicines which are novel medicines just straight out of the laboratory. And so effectively that starts with just some very simplistic understanding of what appropriate consent is, understanding the paperwork which is required, and then understanding about the medications which you are discussing with the patient. So for most doctors that's relatively simplistic to kind of get up to speed with.
Exactly.
And the team at Oxford made it really simple to follow, because it wasn't prolonged, protracted educational sessions. So it meant that was everybody was really, really busy, then this fitted in quite nicely to all the other preparations and the work pressure challenges.
Yeah. So in terms of the treatments and the different treatment candidates, can you tell me how did that translate for your pharmacy department? What sort of things do they have in place to manage everything that's required for that?
So through the last 18 or so months, recovery has kind of gone through phases. So initially started with hydroxychloroquine, olopinavir, dexamethasone, and then it was thinking about interferon beta right back at the very beginning. But most of the medications effectively were available within the hospital pharmacy already. Mm-hmm. Some of the medications that have been used through recovery have been central supplies then distributed to hospital pharmacies, but most, such as dexamethasone, aspirin, these are all ready for the pharmacies to use. Yeah. The biggest challenges that we've had through the recovery trial was effectively convalescent plasma, because that had the most organisation at a national level and also at a local level, which is outside of pharmacy but involves obviously the blood transfusion service and involves quite a few more extra steps with that.
So what helped you overcome that challenge? What steps did you put into place to kind of deal with the convalescent plasma therapy?
So as with all steps with the recovery, the thing that we tried to do, and we did well here, was that we had research nurses who were not pulled back into the clinical team. They were still left to do research, which is great. Many of the projects were put on pause so that everybody could concentrate on COVID, which meant we had a lot of generic research nurses able to come and help with recovery. And the way that we worked it in our hospital was that the research nurses supported the clinical team in terms of randomising the patients and also then linking with our blood bank, quality control, and that really helped our clinical team. So we had lots of interdepartmental working, so pharmacy, blood bank, our research nurses, our clinical team, and those interacting teams really helped to make things work.
Yeah, that's one thing that we've really been championing at South Tees as well, with in the face of COVID, but also in the greater research alliance. It's important to have, first of all, like those specialised nurses, like you say, or specialised research people to carry out and support the teams, but also to integrate. These medicines have been used for other things, so I think people who are used to dealing with patients and in those times are the better people to explain those situation?
Yeah, I mean, some of the medicines such as tocilizumab and baricitinib, these are slightly more niche medicines, so they would be used in the rheumatological units, but not in general medicine. But the principles are the same. So if you're a prescribing healthcare worker, then you should be able to understand the suitability criteria for a particular medication.
So there's one thing I want to talk about with recovery, which is their website, because I feel that it's a really good website for in terms of the dissemination of results. It's got like a little checkboard list of all the different treatments that have been tested and the results that have come with that. So can you give a comment just on the importance of dissemination of research findings and why we need that in our community? Yeah,
well, for any research project, there's no point in doing a research project if you then don't disseminate the results, because there's no point doing it. With most clinical trials, there is kind of years of preparation, years of producing the actual research, and then it takes a couple of years to then disseminate the information. Even when you've got a fantastic trial and fantastic results, it can take quite some time before you've submitted your peer reviewed publication for acceptance and then publication. So the Oxford team have been very good at developing a really patient-focused website so that anybody can go onto it and use it, and there are really clear links to their research outcomes, which is fantastic. So that's in addition to going through the larger national media channels, getting Boris Johnson involved with things as well. So there are lots of different ways, but the important thing is, particularly from a pandemic perspective, if you've got the answer to one of the questions, you need it out into the public domain as soon as possible. And it was really good. So, I mean, the first major result was obviously the dexamethasone result, and it was so good that having started a national trial in March, I think it was either June or July that result was out, which was fantastic. So
that was one thing I wanted to ask you about. How was that received here when the results came out about the treatment with dexamethasone?
Well, I mean, we were really delighted because, again, it's one of the simpler type of medications. We didn't know for definite whether it's definitely helping or not because of the number of patients we had in the trial at that point, but to be able to then say to our clinical teams, crack on, this is the good thing to do, we now have evidence it is going to save lives. It's a fantastic feeling.
And it must give a bit more wind in the sails after such a long period of working as well. Can you explain a little bit why that treatment works?
Well, so we think from a viral perspective that the COVID virus causes a huge amount of inflammation, so a pneumonitis. So we often refer to it as a pneumonia, but it's more of a inflammation pneumonitis, and that causes a number of different issues. So steroids or corticosteroids have been used in many different aspects of medicine to reduce inflammation. They've got many different pathways that they do, but effectively it's an anti-inflammatory type version of medication modulating the immune system, so really reducing that viral insult on the lungs, which is great.
And are there many more treatments lined up to test in recovery? So
recovery, I can't remember how many it's actually tested so far. It must be 11-ish at the moment.
Quite a lot,
Yeah, so we know that through recovery, we know that dexamethasone saves lives. Tocilizumab, which is a medication normally used for rheumatoid patients, that saves lives.
That's quite for the advanced COVID, is it? The toxin?
No, not necessarily.
Okay.
So if you need oxygen and if you've got high inflammatory markers, then you would be suitable for tocilizumab.
Okay.
Alternatively, if you've been very, very poorly and you need to go onto a respiratory support device, you could also get it that way. But the indication for recovery was just a blood measurement of oxygen and blood measure, of inflammation, a CRP, and the oxygen levels. So yes, you can have that. And also, more recently, we had the novel monoclonal antibody treatment, which is Ronapreve, which we used first here in the UK, which was great. And this is the medication that Donald Trump had and thought it was fantastic. And we know that also saves lives. However, as a consequence of changes of variants, unfortunately that doesn't work against Omicron, so we're now not using it at the moment. But we did have those three good life-saving medications, which is great. Currently, we're looking at a diabetic medication. We're looking at high-dose dexamethasone versus now the usual one we're using. And very soon there'll be another monoclonal antibody and also another antiviral treatment. So there are continued treatments coming out because we know that the vaccines have had a massive impact in the patients coming through the doors. But unfortunately, no vaccine is perfect, and there are still patients coming through, and we still need to get better treatments, unfortunately.
Yeah, of course. It'll be interesting to see how those trials progress, the next phases of those treatments. So talking about the general trial conduct of recovery, but also in the future, do you foresee any alterations to general trial conduct, considering like the adoption of novel methods now and the fact that we've shown that we can do things a bit quicker and there are different ways to go about things? Do you see that altering other trials? Yeah,
I mean, I think the recovery trial is a really good demonstration that you don't need to make trials very, very complex. As a secondary care consultant, one of the issues or criticisms with clinical trials is that sometimes the patient group they are looking at is so niche that when you then to generalise it to the big population, it becomes difficult. And that's part of the criticism of several RCTs. So by making trials open and easier to recruit into, the results of that trial then become more generalised and more meaningful, which is really good. The recovery trial, by making it as simple as possible, it also means that you don't have to spend lots and lots of time for an individual person working that trial. You can try and then embed it into normal clinical practice, and that was one of the key things that we did, because right at the beginning we had no treatment for this disease, and so we are actively promoting this trial to patients that you're in hospital, this is a bad disease, we strongly encourage that you take part in this trial because it might give you an extra treatment that might help. And we know that out of the patients that received steroids, tocilizumab and Ronapreve before they were proven to be beneficial, we had 280 patients who had one of those treatments, which otherwise would not have had those treatments at that point in the pandemic. So that's a really good immediate benefit for our patients.
Yeah, exactly. It's part of the duty of care, right, to the patients.
Yeah, exactly. So our duty is to try and make sure we give you, as a patient, access to everything that we can, which would be potentially beneficial. And it's great that we can promote the trial. So what we'd hope is that for other conditions, that people start seeing, well, we need to get treatment for this condition better. We would advise that taking part in this trial is a really good thing to do. And what we hope the trial designers do is they try to minimise the impact on the trials for the researchers and also the patients. So to make it just as easy as possible for patients to take part in.
Yeah, I think that's a really good moment to just say that really being research active as a hospital does give the patients a better chance at having, you know, novel therapies, new treatments, the most cutting edge things, especially when technology is advancing as fast as it is. Like, to be able to keep up with that, like, it's really important to be research active.
Yeah, absolutely. And even just going back to COVID, so because we were so active in using all the different medicines through COVID, once we got the green light for tocilizumab, Ronapreve, Dex, you know, our nursing team knew exactly what to do because they'd already been using it.
Yeah.
So for other units who weren't already taking part in that, it takes a little bit more learning to work out what to do.
Yeah, exactly. But then that comes back to having the importance of having the collaboration between your different departments and the integrated teams who are ready to, you know, immediately implement the outcomes. So what do you think will be afforded in the long run by recovery for not just the hospital but the region? So I think there's a little bit of a spotlight on the north at the moment, thanks to, you know, the successes of the trials, not just recovery but the Novavax and different things that have gone on in the region. So what do you think that will mean for the future?
So I think particularly for the North East and Cumbria, it really demonstrates that this is a very research active area. Newcastle has always been a focus for research with the university there, but I think the rest of the region has now been identified and is now nationally seen as a research active area. That's whether it's in trust-based research, so ourselves and also South teams were amazing at recruiting into recovery, but also the Northumbria Trust as well were doing really, really well. So the whole region as a entity has recruited far more patients than many other regions, which is fantastic. And as you mentioned, so the vaccine trial is fantastic. The Discovery Centre at Darlington is another very different aspect of research, but is cutting edge.
Is that the Horizon Centre?
Yeah, the Horizon Centre.
I've actually got a conversation with Vicky scheduled, and so I can hear a little bit more about those novel diagnostics. But that's a place that's really probably pivotal to some of the successes that we would foresee in the next few years, I guess. Yeah,
absolutely, and it just proves you don't have to be down at London to do research. You know, it is here. It is in the North East. It is part of the North East. There's
people in the north, and we're active. So the trial's still ongoing, but what's next for you in terms of your research conduct here?
So we are continuing to work on recovery, and we'll continue to support recovery as whilst we have patients coming through. We are really pleased to say that we are getting less and less patients coming through with respiratory failure due to COVID. We are still seeing lots of patients coming in with COVID, but often their patients have got COVID but have also got something else like cellulitis or something, and are not here because of the COVID, which is great. But there are still some patients who the vaccine hasn't quite worked for. Part of the challenge for us and other sites is trying to continue to do COVID research, but bring back online all those projects which were put on hold, and also start new research, because clearly all the other diseases that were there before COVID are still here, and they still need to be. So our challenge within respiratory in this particular department is to try and get back on top of the other research projects. So we've got projects looking at pleural effusions related to heart failure. We've got new projects looking at fibrosis, but we are very much still focusing on being a recruiting centre for portfolio studies rather than starting our own research at this particular moment.
I see, they're all starting up again slowly and surely, but hopefully the new adaptive trial study design will be beneficial to, you know, tackling all those issues that were already there and still need to be tackled.
And as I mentioned, I really hope that, you know, the trial design is just try and keep things as simple as possible to make it, you know, easy for everyone.
And we've had a conversation recently within the DTVRA about how we can do that, so about kind of digitising recruitment processes and having, you know, tablets available to people, and so it's a little bit more user friendly. And I think recovery really set the precedent for in terms of the website and the dissemination of that result, and I think that would be a good sort of benchmark for other trials to follow in terms of keeping the participants up to date with the results, because, you know, that's the foundations you build in for the future participation. If people are looked after and have heard the results of a trial, like you said, it can take a long time for a lot of different reviews to be written and analysis to be done, but if people see their work that's being done, and there's that level of transparency when it's on a website. Hopefully that will encourage more people to take part.
And one of the different things that happened through COVID and through recovery is that we had regular national Zoom or then MS Teams video meetings with the team, which is fantastic. So before, I mean, clearly all of our working practices has changed as an impact of COVID, but actually demonstrated that you can do relatively quick catch-up meetings. You don't need to pre-book a whole day to go down to somewhere in Cambridge or Oxford.
Exactly.
And that worked really well because it's a way of just a two-way conversations, but at a national level, and it's a great way. So I hope other trials will continue with that format as well.
Yeah, exactly, because it used to be obviously like the site induction visit or monitoring visits would be the only time you have the contact with the sponsors or different people coming to site, but like you said, having that open communication channel with just a regular catch-up is really, really useful. So are there any other takeaways that you would say people need to kind of uplift going forward? How would you put wind in the research staff's sails?
Well, I would say, I mean, the key point is that, I mean, for all the team members that have been involved in research and recovery, you have changed lives because, you know, without us doing what we all did and being a major recruiter into recovery, we would not have had the answers as quickly. So the research nurses have changed lives, as well as everybody else. That involves the patients who volunteered to take part, the doctors, and we've had a really fantastic response from our junior doctors who are involved with the trial. And for them, it's demonstrated that research is not just something theoretical you read in a textbook. It's there, it's ready to be engaged with, and there are opportunities definitely in whichever hospital you're working at.
Exactly, it's a basis for all, and I think a lot of the research consultants that you speak to and different PIs, the research involvement comes from way back from the studying time. So that's hearing that the junior doctors are already involved. That's great because it doesn't become extra to the workload. It's already there. It's already an involved part.
Yeah.
And so just finally, do you have any advice for anybody who's working in a hospital currently and maybe intrigued by research and wants to get involved? What would your advice be for them?
Yeah, so I think whatever your current role is within the NHS, there is an option to get involved with research. If it's not particularly obvious to you, one of the easiest first places to go is to the research and development team within your hospital. If you're working with a particular speciality, just go and see one of the senior members of that department, and I'm sure they'll point you in the right direction. Research doesn't need to be all-consuming, dedicating your entire time. Some people just need a little bit alongside with their normal activities. Some people do want to take a bit more time for one day a week, etc. And there are significant ways to try and formalise your education within research. But if you just want to start just getting a bit involved, there are definitely ways to do it.
Yeah. Okay, great. Well, thank you for that.
Thanks very much. Nice to meet you.
Thank you very much for listening. If you would like to engage with us about any of the content, please feel free to use the contacts listed here.